There is a need to have a practical framework when facing with real-world dilemmas such as asymptomatic ejection fraction decline, mild biomarker elevation, new LV dysfunction during therapy, and balancing cardiovascular risk with oncologic urgency. So, how do we decide when to continue, pause, or stop cancer therapy? Cancer therapy related cardiovascular toxicity, or CTR-CVT, is a term used to define a wide spectrum of cancer therapy that can injure or aggravate the cardiac and vascular system, such as accelerated atherosclerosis, vasospasm, conduction abnormalities, and other side effects. For cardiac injury, cardiomyopathy, and heart failure, the descriptive term is cancer therapy related cardiac dysfunction, or CTR-CD. This was further divided as asymptomatic and symptomatic, and further classified according to EF cutoffs and severity of symptoms. When we get to see cancer patients in our clinics, apart from getting details of risk factors, a thorough clinical assessment, taking into account previous cancer treatment, cardiovascular history, PE, and complementary tests such as biomarkers, ECG, blood tests, and 2D echo are recommended. From this, we could already assess those patients who are at high risk to develop CTR-CVT. Let me present a case of a 65-year-old female, hypertensive with invasive breast CA, who had previous anthracycline treatment. The plan for this patient is to have trastuzumab infusion. Baseline tests were done, which showed elevated NT-proBNP with normal ECG and 2D echo. Her EF was 58% and GLS of negative 20%. However, on the third month of treatment, patient was noted to have a symptomatic decline of her ejection fraction and an abnormal GLS. For this patient, should we continue, pause, or stop cancer therapy? For this particular patient, we could already start her on cardioprotective strategies such as giving ACE inhibitors or ARB or beta blockers. Cardiotoxic therapy can be often continued if the toxicity is mild or properly managed. If ejection fraction drops slightly, which is a drop of 10 to 15 percentage points but stays within normal limits, we should continue treatment with close surveillance. For asymptomatic moderate dysfunction, which is mild to moderate, about EF of 40 to 49%, we should initiate cardioprotective therapy and continue treatment while monitoring closely rather than automatically stopping. And for patients with cancer that is responding well to treatment and no or less effective alternative options exist, the benefit of treating the cancer may outweigh the risk of cardiac toxicity. Therapy should be paused or stopped in cases of significant symptomatic or progressive heart damage. So for severe symptomatic LV dysfunction or heart failure, this requires immediate interruption of cardiotoxic agents. For anthracycline with asymptomatic dysfunction, we should stop or interrupt treatment if EF drops to less than 40%, or if there is a severe decrease of about 20 points. If the ejection fraction falls for HER2 asymptomatic dysfunction of less than 40%, stop therapy and initiate heart failure management. For immune checkpoint inhibitors, if myocarditis is suspected, we should stop immunotherapy and initiate high-dose steroids. For acute coronary syndrome, if 5-FU causes acute chest pain or coronary spasm, stop the medication and avoid rechallenge, or carefully reconsider only after expert consultation. Rechallenging or resuming therapy, particularly anthracyclines or trastuzumab, can be considered after the heart has recovered or when risks are managed. Never restart a cardiotoxic agent after severe damage without a joint decision from a cardiologist, an oncologist, or hematologist. Rechallenge can be considered if ejection fraction recovers to equal or more than 50% after stopping, provided that the patient is on optimal heart failure therapy. For anthracyclines, we can consider switching to liposomal formulas. For vascular toxicity caused by 5-FU or capecitabine, for patients who experience cardiac pain, it may be possible to restart with prophylactic calcium channel blockers, nitrates, or by switching to a different regimen. For her to rechallenge, if the patient is asymptomatic and the EF has recovered to equal to or more than 50%, trastuzumab may be resumed with close monitoring. And we can also use lower infusion schedules or dose reduction as alternative strategies. When CTR-CVT is present, the risks and benefits of ongoing cancer therapy must be carefully considered. This decision involves discussion with the patient, their caregivers, and treating healthcare providers. If the risk-benefit relationship is favorable, a strategy of permissive CTR-CVT may be adopted. This approach allows the continuation of cardiotoxic treatment under close surveillance, accompanied by appropriate cardiovascular therapies with the goal of optimizing cancer treatment delivery. These are the recommendations in permissive cardiotoxicity. For our patient, she could already continue therapy with mild, minimally symptomatic LV dysfunction, but there is a chance of 5 to 10% incidence of heart failure. So what do we do? This is the recommended surveillance for cancer treatment. So for our patient, we need an echo every 3 months during treatment for adjuvant or neoadjuvant therapy. But for metastatic setting, we could measure LVEF every 6 months, and an echo is the preferred method to measure LVEF. For the other types of cancer treatment, these are the recommended surveillance, which include strict BP monitoring, QT prolongation monitoring through ECG, and use of biomarkers. This is just a simplified summary of the options, whether to continue and interrupt cancer treatment in general. Deciding whether to continue, stop, or restart cardiotoxic chemotherapy requires a personalized, multidisciplinary approach that includes cardioprotection, surveillance, and weighs cancer prognosis against the risk of heart failure. Thank you very much.